Hello everyone. In this video, we shall see in detail about mineral trioxide aggregate and its applications in endodontics. Mineral trioxide aggregate, commonly called as MTA, can be considered as one of the golden material which has revolutionized the field of endodontics. Even we can split the uh, endodontic era before the introduction of MTA and after introduction of MTA. We can say that it is a golden material which has saved millions of teeth worldwide because of its wonderful properties and the success rate that has been shown to be highly good and better compared to any of the previous material which were used for the same purpose. Let's clear it out, some of the applications of mineral trioxide aggregate which can be used in the field of endodontics and the way to be used and what are the situations that it can be used. This will be like an insight into the mineral trioxide aggregates and its applications. By the way, I am Dr. Benin Palayan, and if you are a dentist or a dental student watching this video, kindly consider subscribing to my YouTube channel Smart Dentistry. I will make videos that will be useful for dentists and dental students. And if you are a beginner starting with rubber dam in your clinical practice, I highly recommend you people to enroll for this program in Udemy made by me, which is called as the Rubber Dam in Clinical Practice, a master course. I will put a link in the description. Kindly enroll for this program. I hope that this program will be really helpful, which will clarify any of the doubts or the different techniques, especially the easy techniques which are clinically applicable that anyone can practice in your day-to-day clinics. Okay, now let's proceed with MTA. The first application that I am going to explain is perforation repair. However good you are, whatever you are, and how experienced you may be in cases of malaligned teeth, in cases of attrition, in case of calcified pulp canals, in those situations there are chances that you might end up doing perforation. If perforation happens, everyone may get exhausted thinking that what should I do now? So the simple trick for the management of perforation is seal immediately. With what material? With the best material which could be used for sealing a perforation is mineral trioxide aggregate. We can see that there is a furcation perforation in this case, and what we are supposed to do, clean that area and make sure that you can use sodium hypochlorite to disinfect that area, and we can seal that location with at least 2 millimeters of MTA. MTA has to be mixed to a slurry consistency or a putty consistency, and then it has to be packed in that area as soon as possible is going to be the best treatment. If you have perforated and after 2 weeks, if you are going to seal with MTA, the infection would have been established in that area and your success is going to be very less. So whenever perforation happens, the first and the foremost that you have to do is seal immediately, and the material of choice is mineral trioxide aggregate, or alternatively you can go for similar material like biodentin or CEM, calcium enrichment mixer, but the readily available material and which can be used with predictable success rate, I would always go for mineral trioxide aggregate. So after sealing with mineral trioxide aggregate, we may proceed with the continuation of the root canal treatment, and the root canals can be filled and the permanent restorations can be made. So the success rate is close to 100% if you are sealing the perforation immediately. So if it is delayed or if it is in a location there it cannot be sealed properly, then the success rate may be compromised. But in all the remaining situations, the success rate is going to be very good if you can use mineral trioxide aggregate. So mineral trioxide aggregates, the first application is perforation repair. So the second application, which is which with a general practitioner should be aware of and should be thorough in doing is apexification. We get this type of cases in our day-to-day practice very often. The patient may be around 15 years old or maybe 20 years old, maybe 4-5 years they might give a history of a trauma, and the tooth may look normal outside, or it might be discolored, or there may be some mild fracture, but there might be a sinus tract, or the tooth recently would have become symptomatic, and if you take a radiograph you can notice a widely open apex. We call it as the open apex. This is getting more and more popular nowadays because there are more child getting this type of trauma and goes unnoticed, and maybe after 2 or 3 years they come to the dentist for the treatment, and the root wall being thin and the apex being open, doing root canal treatment in these situations are not possible. So what the remaining option is, first we have to do cleaning and shaping, and then preferably we have to disinfect the canal 100%. In the last video I have mentioned about the triple antibiotic paste in the intracanal medicament video. So if you haven't seen, I would recommend that you can watch that video. So it would give an idea about what medication have to be used for each and every clinical situation. So triple antibiotic paste is the ideal intracanal medicament in this situation. We can pack it for a week or two. So after that we can consider the canals are highly sterile, and after that we can pack the apical 3 to 4 millimeter with MTA. And if want, after packing with MTA, in order for the MTA to set, it needs moisture. If you want, we can place a cotton pellet and we can recall the patient after a week, and then we can proceed with the backfilling with gutta percha. So the backfilling can be done with gutta percha. If you are not using a thermoplasticized unit, even you can use lateral compaction in order to fill the back spaces. So this gives a good seal by the MTA. So shall we do MTA apexification in a single visit? Yes, definitely we can do MTA apexification in a single visit. And if you are familiar already doing apexification with calcium hydroxide, then MTA will be the better option or the better choice. That with this the success rate is highly improved compared to that of calcium hydroxide. Again, with calcium hydroxide we have to do visits again and again, 4 visits, 5 visits. It may go for a long time, maybe for months or years together, in order to form a calcific barrier. But mineral trioxide aggregate will act as a calcific barrier, and we can say that what the calcium hydroxide could do in a year, the MTA could do in minutes. So, and actually if you want, you can fill the remainder of the canal also with the MTA, and that will provide some resistance to fracture for the root canal walls if it is quite thin. And I hope that this gives an idea. So for the placement of the apexification MTA, and it's similar to the placement procedure for calcium hydroxide, and if you are not familiar, just put in the comment. I will make a separate video how to place MTA in the apical area in the simplest way and the easiest way, because with little experience that technique will improve if you are following the appropriate technique. So if you have done this properly, and even the apexification, the apical lesion will heal, and we can expect a very good success rate. The next application that we are going to see is, just have a look at these pictures. We can see a first molar, second molar, and a third molar with different levels of the pulpal inflammation or dental caries. The dental caries in first molar has just touch the pulp without causing any inflammation. So in the second molar, we can say that the dental caries has touched the pulp, and also there is a partial inflammation in maybe the localized area in the coronal pulp. And in the third molar, we can see that the dental caries has touched the pulp and almost all of the coronal pulp is inflamed. Maybe the patient is reporting with severe pain. So the first situation we will see, we are going for pulp capping. So in which situation we go for a pulp capping is the caries has just touched the pulp and there is no obvious inflammation has been established in the dental pulp. In those situations, what we can do is just remove the caries. Rubber dam is must. Under rubber dam isolation, remove the caries. After a complete caries removal, disinfect the area, that is the lesion, with sodium hypochlorite. After disinfecting, pack the pulp. On top of the pulp, place a thick 2 to 3 millimeters of MTA. And after placing MTA, the remaining area can be filled with the GIC, and I would recommend GIC will be a better material in these situations. And maybe after a week, we can remove maybe the coronal 2 millimeters and we can replace with composite or any material of your choice. What will be the success rate? It is highly successful. We can expect a success rate more than 90% in direct pulp capping with MTA. The alternative material, the calcium hydroxide, with direct pulp capping, the success rate may be around 60 to 70%. With MTA, more than 90%, we can expect it to be a successful treatment. So the next option is that the pulp has been involved and partially it has been involved. So in those situations, we can go for a partial pulpotomy. So after removing all the caries under rubber dam isolation, with the help of a sterile burr, make sure a sterile burr, preferably a new one, a sterile burr, we have to remove a partial portion of the pulp which is in contact with the dental caries. And once we can remove that area without damaging the remainder of the pulp, then the area have to be packed with mineral trioxide aggregate. So once we pack that area with MTA, the coronal area can be filled with any of the permanent filling material. And again, if the tooth was not very symptomatic before, then it is going to be a successful treatment. We can practice these techniques in young patients, maybe less than 20 years of the old. We get young patients coming with deep decays, and once we open up, there may be a bleeding which could be stopped within a minute or two. In those situations, instead of proceeding with the root canal treatment, pulpotomy will be the best option. Nowadays, I practice more and more of these procedures and I find it is highly effective provided you are using rubber dam and you have not contaminated. So this is a wonderful procedure and it is an easy procedure once we start practicing it. So again, partial pulpotomy can be done and maybe the success rate we can expect around 85 to 95%. It is going to be successful. And the next one is, which maybe we can say that the hot topic that is nowadays, which is happening in the field of endodontics, which is called as the full pulpotomy in patients having irreversible pulpitis, that the pulp is maybe the entire coronal pulp is inflamed and the tooth is symptomatic. Even in those situations, what we can do is under rubber dam, just remove all the decay, disinfect the area, then you have to, with a sterile burr, remove the coronal pulp completely. Only the coronal pulp. You are not going to use a file, you are not going to insert any instrument inside the root canals. The coronal pulp, just we can cut it off with a burr, with a sterile burr, and we can use sodium hypochlorite to stop the bleeding from the radicular pulp. Once we could do that within a minute or two, means the radicular pulp is not that inflamed. So once the root canal, the pulp inside the root canals or the radicular pulp is not inflamed, then there is no need to proceed with root canal treatment. Just we can pack the root stems, that is the pulp stems, with mineral trioxide aggregate, and then you can go for a permanent restoration. Is it going to be the recent studies and the literature states that it is maybe close to 95-96% is the success. in case of permanent teeth with symptomatic pulp. I would recommend that if the patient is less than 20 years of age and the tooth has become symptomatic in a day or two and it's not long standing, and if the pulp vitality states that the tooth is early stages of irreversible pulpitis, again we shall go for this type of treatment that is highly effective. And if you are interested in knowing about the diagnosis, how to differentiate whether the tooth is vital or non-vital, yes, we can use pulp vitality. And how come we can say that it is the caries has just touched the pulp and the pulp is not inflamed, or the pulp is partially inflamed or it is completely inflamed? It takes little time and with the help of some signs and symptoms, and I hope that that topic is totally a different one. And if you are interested in knowing about the diagnosis in pulp, just let me know in the comments. I will make a video about diagnosis in endodontics. It will be a beautiful topic, especially for those young dentists and the students who are starting with root canal treatment or with any of the clinical practice, in order to make a decision whether we can do a restoration or a pulpal treatment or a root canal treatment. In those situations, it will be really helpful. Let me know in the comments. So that's about a direct pulp capping, about partial pulpotomy and full pulpotomy. And let's move on to the last part of this presentation, the retrograde filling material. So in the past, after doing an endodontic surgery, amalgam or IRM or many other materials were attempted as the retrograde filling material. But after introduction of MTA in 1992, after that mineral trioxide stands as the golden material or the gold standard material for such treatments. So let's see that there is a tooth maybe which is pulpally infected and there is a periapical lesion. You did cleaning and shaping and you finished the root canal treatment. Maybe after 6 months also the tooth is still symptomatic or the periapical lesion is still persistent. In those situations we have to go for a root and surgery, that is the periapical surgery. So in those situations, after anesthesia, we have to reflect the flap and we have to reach the lesion, and 2 to 3 millimeter of the apical portion have to be cut with a burr. After cutting with the burr, with the help of the ultrasonic retrograde preparation tips, for 2 millimeters we have to prepare a cavity, and this cavity has to be filled with some material called the retrograde filling material. For this, MTA is the material of choice. There are no other material which can come even equal to this. So why MTA is such a wonderful material? How that is going to be highly such a good material for the treatment to be successful? It's because of its sealing ability and its biocompatibility. So it is highly biocompatible and it has a wonderful sealing ability. It seals completely and with time the seal improves. So once the seal which is provided by the material is better, then the treatment is going to be always successful. So the mineral trioxide aggregate can be used as a retrograde filling material during endodontic surgeries, and there was a old practice of just heating a burnisher and just rubbing the exposed portion of the gutta percha. That is no more accepted as a treatment option, and if someone is practicing that, it's the time to shift to the retrograde filling with mineral trioxide aggregate. The procedures are very simple. In the past, again, the preparation of the retrograde, the cavity preparation in the root end is going to be, it was very difficult, but with the help of the ultrasonics it hardly takes 2 or 3 minutes, and just placement of this, we can use an MTA carrier and we can place it, pack it, you can check in a radiograph. And one more advantage of the MTA is, even if blood comes in contact with it immediately, this MTA will not get washed away. That will be highly stable. So these are some of the advantages of MTA, and if you have never used MTA, you have missed the big picture, and it's the time to start using MTA and MTA will make your treatments success. With that, I conclude that MTA can be considered as a golden material, and there are different products of MTA are available. So the first introduced and the most popular material is the ProRoot MTA by Dentsply. Maybe a bit expensive, but I exclusively use this material. That's a wonderful material for almost all the treatment options that I have mentioned. And MTA Angelus, it is a more affordable material. Again, with a good success, we can use this material too. And there are many other applications of MTA, like it can be used as a root canal sealer or in many other applications. So I have covered only as the basic purpose or the basic indications for MTA in the field of endodontics. It has multiple applications in the field of operative dentistry also. So today we have seen only about MTA in endodontics. I hope that this provided a little insight about mineral trioxide aggregate and its applications in the field of endodontics. And thank you for watching till the end of this video. Have a nice day. Thank you.